Okay, good evening and welcome to the New Orleans Conference 2019 online edition, the only true dedicated online ABCP CEU program. I am your host, Joe Basha. So we are all not physically in New Orleans, but we are going to bring some of New Orleans to you through your computer. We have some music. We have some New Orleans graphics, and we even have some beads. You know what they do in New Orleans? You know what they do there, right? They throw beads at you. They throw beads. Okay, so this year 13 of the New Orleans Conference, we are here online. I remember our first year of the New Orleans Conference, a year post-Katrina, when we had only 23 participants at the DoubleTree Hotel, of which 10 were faculty, but in New Orleans. But we had so much fun. By year 12, we had over 230 participants, and we had honored some true titans of our field. Dr. Ochsner, Dr. Cooley, Dr. Bailey, Dr. Mack, Dr. Robachek, Dr. Broadman, Dr. Webb, Dr. Frazier, and from last year, Dr. Tyrone David from up in Toronto. Man, these are and were some great people, and I feel so humbled and privileged to have had the opportunity to know each of them. Of course, we have already lost Dr. Ochsner and Dr. Cooley, and just recently Dr. Bailey, and it is very saddening to me. But the conference, and moreover, their graciousness at our conference, was so unique and special, and is why we chose to award them. We have also had some great faculty. Dr. Blitz, Dr. Jones, Dr. Edwards, Dr. Trotter with his great history lectures, Clint Robertson, Brian Cheatham, who survived Hurricane Maria down in Puerto Rico, Dr. Badia, Dr. Matoyer, an ethicist, PhDs, and a host of others, including General Honore, an FBI agent, and even a real-life mafia gangster. It has been one hell of a ride. Now we are going to try to develop the MediWeb, PerfWeb, and PerfusionEducation.com online programs to match the uniqueness and quality you came to expect at our on-site annual conference, the New Orleans Conference. We have started by developing this studio and streaming technology that gives the program a professional and inclusive feel. We are also so appreciative that you have invited us into your homes, offices, or wherever you may be watching us from, and we are working very hard to bring you quality programming that is interactive and not only very informative and useful to you, but programming that is also enjoyable to watch and to be a part of it. We are the best, and we will continue to be the best. Now, this part is very important. We are on all social media platforms. Please like us on Facebook, follow and share us on the Twitter, subscribe to our YouTube channel, and you can chat there too. And I'm monitoring that chat right now. Oh, and don't forget to click the bell to receive notifications, that bell icon. You can also call in when you see this announcement. And you can be live on the air and ask your questions, discuss things, make comments, whatever it may be. Be part of the discussion. In fact, we love it when you do that. We really encourage you to do that. We are also recruiting faculty. If you would like to be a part of our faculty or know someone that you think would like to participate and be a part of your revolution in continuing education, please have them email me at this address. We are also expanding to develop NurseWeb and Nurse CE programming for cardiac and critical care nurses. So please let your friends and colleagues know. Okay, So here is the schedule for the next 3 days. We have tonight, fluid, volume, and blood management, a multidisciplinary approach by Keith Smolik. We have Transfusions, When and Why by Tammy Sparacino. We have the Physiology of Fluid Management, again by Keith. And then tomorrow, Saturday, we'll start off with Dr. Badia, Validating Graft Patency. We're going to do a brief off pump. Why does it still happen? That's going to be just a little bit of a discussion. Another true story in the heart, true story of fire in the heart room by Dr. Badia. He was the surgeon in that particular case. Ethical considerations for allied health professionals, Debbie Adams, and she has something to talk about in terms of her lessons that she received from Charlie Reed. We have Dr. Borat Gersak. I'm sorry? Did I say it right? Hello? David? No. Okay. Dr. Gersak talking about the sutureless valve, an excellent option for SAVR. Perfusion Standby and the TAVR. Yours truly is going to give that talk. And then Sunday, we wrap it up with Dr. Hani Samir, great guy, really interesting. He was chief of cardiac anesthesia at Houston Methodist Hospital, the remote ICU intensivist. He's going to give both of those talks, which he is doing now as a telemedicine intensivist. And then an interview with the AMSEC president, William Dubois. That is going to be a very, very, very good talk. I'm excited to hear that from Bill. Okay, we can come back up. So I think what we need to do now is I think, Keith, you need to get your slides ready to go. So while you're doing that, let me introduce Keith Smolik and also Tammy Sparacino. And then later in the program, we're going to be joined by Stephanie Ebus and Rodell Ebus, both perfusionists. I'll introduce them later. But Keith, while you're getting those slides ready, first started working at perfusion in 1989 at Johns Hopkins, and has worked in the Mid-Atlantic and New England areas, and he is still very involved in the field in many ways. He is currently the liaison to the blood management medical community of SABM and its networks for AMSEC, as well as the AABB liaison for perfusionists from AMSEC. He is a director for the International Board of Blood Management and certified patient blood management specialist. He was on the steering committee for the New Advances in Blood Management Organization, perfusion meetings in Jackson Hole, Wyoming, and Kansas City for the last 10 years. He is a past chair of the SABM Perfusion Blood Education Committee, was on the guideline writing committee of the International Board of Evidence-Based Best Practices, has authored peer-reviewed publications and guidelines. He has developed, patented, and brought to market an innovative blood salvaging device, the HemoBag, and method for saving autologous whole blood in surgery, with sales in the US, Canada, and globally. He has received the AABB's highest award, the Dale E. Smith Award for Innovation, Pioneer in Blood Conservation from the National Blood Foundation. Currently, he is serving full-time as the president and CEO of Global Blood Resources, and is also the chairman of the board. Sitting next to me is Tammy Lee Sparacino. Welcome, Tammy.
Thank you.
And welcome, Keith.
Hey.
Tammy is a sixth-generation Texan. That says that's something, okay? Graduated from the University of Houston in 2001, and then Texas Heart Institute in 2003. Spent a majority of her career in community hospital settings, and her areas of interest is in ECMO circuitry safety and blood conservation. And you're going to be giving a real good talk too on why do we transfuse. I think that's going to be transfusions, when and why, because we see it all over the map. So have we got Keith's slides up and ready to go? Okay, outstanding. So Keith, welcome to the program once again. Thank you so much. Where is Keith? I can't see him.
Well, you can't see him because he's on Skype.
Oh.
Share the screen.
Okay, well, we'll say hi to Keith after he finishes his talk then. Keith, can you bring him up so we can say hello to him?
Well, he'll have to minimize his. That's he has to do.
Oh, okay, all right. Well, Keith, go right ahead, and we'll bring you up and show everybody what you look like later.
Perfect. Thank you, Joe.
Okay, go ahead.
Okay, so starting tonight, I wanted to thank you, number one, for inviting me to participate in this. And number two, I've got two-part slide presentations. The first one is on a multidisciplinary, multimodality approach to autologous blood conservation. And the second part is going to be more on the fluid volume dynamics. But it all has to do with blood management or fluid management more specifically. So I'm just going to start right now. Okay, my disclosures for tonight. I'm the president and CEO of the company and founder of Global Blood Resources, the maker of the HemoBag blood salvage device for salvaging blood from extracorporeal circuits. And I will be talking about that in little bits tonight. So when we talk about, and again, this is going to be sort of 101 as well. So let me just start here with the ethics of blood management. First, the old primum non nocere, do no harm. When you transfuse, you want to only transfuse what is absolutely necessary. In the old days, they used to say things like, crits down, can I give me a unit of blood? They're like, well, give two. That's not how you do it anymore. It's give one, recheck to see if you need to give another. So again, only what's absolutely necessary and only sparingly. You want to use the freshest components possible. I think everybody have seen older blood get really dark, almost chocolatey, and you want to use the fresher blood. Under 15 days is supposedly the best. Then the cells are still much more intact, and there's not as much hemolysis and acidosis. You want to use minimum sampling. So we can do PEDS tubes on, a full CBC and coags on kids with PEDS tubes, but with adults, we seem to draw 3 to 5 mLs per tube. And, if you're drawing 3 tubes a day or, 3 sets of tubes per day, you're causing an iatrogenic anemia. You want to avoid waste. You want to recover as much autologous as possible. You want to use point-of-care labs to justify your transfusions. You want to use evidence-based medicine to guide your decisions. And you got to remember, it's not blood management, it's fluid management, and blood is just one of those fluids. Now, there is an article that came out last year, and it talked about the crisis and the sustainability of the U.S. blood supply. So I would encourage people to look at that if they can. So again, starting, what is blood? Well, we know it starts off in the large bones as pluripotential cells, and then it differentiates out into anything. White cells, platelets, plasma, skin, hair. So the 4 major components, what we're talking, we're always talking about, is, red cells, white cells, platelets, and plasma. Of all the blood products that are given to patients, there is one that causes trolley. Okay, so again, of all the blood products, the one the most likely is going to cause trolley, which is the number one reason for morbidity and mortality for transfusions. It's from FFP. So what happens is women that have delivered or had children already, if they donate their blood, their FFP seems to be the hallmark for people that end up getting trolley. And again, trolley, transfusion-related acute lung injury. You get a whiteout, you get on a respirator longer. It's the number one reason why people have morbidity and mortality from blood products. So when we talk about the multidisciplinary approach or people in the chain, remember, it's door-to-door hemovigilance or it doesn't work at all. So you have your primary doctor that you normally visit once or twice a year, a cardiologist, an admission care person, anesthesia surgeon, perfusionist, the ICU care team, nurses hospital-wide for that matter, and you have administrators as well. It only takes one weak link in the chain, and the patient is then exposed to donor allogenic blood products. So it takes a hawk-like multidisciplinary teamwork, and that's the only way that it works. You have to treat every patient like they were a Jehovah's Witness with a small BSA for best practice outcomes. So getting back to the players, the primary doctor, you're out shoveling or you're doing some hard work in the yard and you get some chest pain, you go see them and they start to do base lab work with you, lab work. Preferably, again, 6 weeks earlier than your surgery would be ideal unless it's really acute. Do you want to use microsampling or PEDS tubes? They may consider iron therapy or EPO therapy to get you tuned up with your red cell mass before you go for surgery. This primary doctor may suggest a good hospital for you or a good cardiologist, and that'll help select maybe a surgeon for you as well. So the cardiologist, when we work with cardiologists, and I know a lot of the listeners will have been in a cath lab and they've seen this before. But again, you want to do the minimal labs with microsampling at all times. You want to pay specific attention to bleeding during the cath. Now, a lot of times in the old days, they used to do femoral caths, and they used to put the introducer in, and then they would take it out, and they would let it bleed to make sure that it was patent. And you'd lose anywhere from 200 to 300 mLs or even more in that just to make sure it was patent. The other thing that they used to do, I haven't been in a cath lab in a while, but they used to like to use heparin, and they would have that ACT machine ring out like almost 1,000. You know, if they thought it was greater than 500, they'd give more heparin. So the deal is, of course, nowadays we all know that we don't need 999. We can get by just fine with 300-400. All right, the use of newer antiplatelet drugs is best. Less is best. You want to identify the best hospital to have surgeon at. You want to identify the best surgeon to do the cases, a real specialist, somebody that does Jehovah's Witnesses. And again, if you have more than 2 easy stents without stent jail, send me to cardiac surgery, as grafts last longer. The overall mortality rate for on-bypass mid-sternotomy is less than 2%. Everything else is 5 to 10%, mid-cabs or off pumps or all that kind of stuff. So again, if it's less than 2 and it's easy without stent jail, get the surgery. All right, now you have your admission care team. Preferably the day of surgery, you come in early. You've already been without any food or water for 12 hours. You want to do microsampling. You got to remember that once they put an IV in, that's when the games begin, because now they have access to give you fluids. And for every liter of fluid of crystalloid given, only 2 to 250 mLs will stay intravascular where they want it in 30 minutes. The remainder, or the 750 mLs, will cross extravascularly, cause an organ edema and organ dysfunction, and that really drops the viscosity and osmotic pressure. You should never give patients IV fluids unless there's an excessive volume loss from urination or bleeding. Perspiration and insensible volume loss are negligible in a perioperative setting and may amount to about a liter or so in 4 hours. But if you must give volume, we all know there are 2 types. There are crystalloids and there are colloids. And crystalloids are aqueous solutions of mineral salts and other water-soluble molecules, and colloids are generally larger insoluble molecules such as albumin, gelatins, and blood itself is a colloid. So when we look at the crystalloids that are given, we can see these are the ones that we deal with on a daily basis. And as I said earlier, for every 1 liter of crystalloid fluids given to a patient, only 200 to 300 mLs is going to remain where you want it in 30 to 45 minutes. Dilution leads to organ dysfunction and a coagulopathy. If you see the guy on the left, he's a happy camper. His crit's 40 and his lungs are nice and clean. And if you look at the person on the right, he's gotten too much volume. His crit's only 23, and you can see he's already having problems. And as you know, fluid always wants to find its lowest level or equal out. So you're going to have a low solute concentration. That water is going to move to the higher solute concentration to equal out. So before surgery, the pre-game plan, or the big 3, what I always say, perfusion, surgeon, anesthesiologist, whenever possible, the members of the cardiac team should try to communicate before the surgery starts. The surgeon, anesthesiologist, and perfusionist should meet prior to surgery and discuss the best course of action for optimizing the case and avoiding allogenic blood products. Remember, it's a team approach to blood management. I always liken it to everybody's playing an instrument, and if one person is not playing the same song, it sounds awful. But when everybody's playing the same tune, it sounds great and it works well. So when we talk about anesthesia, on the top left there, it says 8 grams to 10 grams of hemoglobin, and I'm going to come back to that. So with anesthesia, it's meticulous placement of lines to function correctly and not lose any any blood or make any extra holes. And remember, the new residents start in July. Usually it's late June or early July. They're around and they're learning on you, the patient. You want to limit the amount of crystalloid given during the case and opt for colloids like albumin instead for volume. This is a huge one, vascular tone or SVR. You want to, gingerly use pressors as tolerated by cardiac index to achieve a normal SVR between 8 and 1,300 dynes per centimeter squared. Acute normovolemic hemodilution is a technique that's been used for years now. I think it's a good thing to do. There's a lot of people doing it. But usually you can take 1 to 2 units or more, can be removed safely, and still keep a good crit while on bypass. And this blood will be, rocking off outside of your body until the end of the case. And it's the first volume you'll see after the case. And, there's a lot of reasons why people say they use it because, the platelets are not as beat up, but I don't necessarily agree with that. Targeted pharmacotherapy. Amicar, DDAVP, recombinant factor 7A or Novo-7, vitamin K. K-Centra is a big one now. K-Centra's got factors 2, 7, 9, 10. It's got some fibrinogen, protein CNS, AT3, albumin, and it's even got heparin in it. Red cell mass actually contributes to hemostasis by pushing the platelets out to the endothelium where they come in contact with the denuded endothelium. But it's got to be a crit of at least 24. If you look at those little white dots, if you look at this, we'll call this an artery. We cut it, we're looking straight down the middle. You'll see the heavy red cells stay and tend towards the middle like a freight train down the middle. And it pushes the platelets to the outside or the perimeter where they will come in contact with the endothelium. When the crit's less than 24, those little white dots or platelets, they tend to mix towards the middle and they don't necessarily do what they're supposed to do. So a crit of 24 is key. Anesthesia. Continued again. Hypotension is not hypovolemia. There's a couple of great articles. One of them is from a guy named Chappell out of Germany. He wrote a paper, and I would fully advise everybody to read that paper. It's logical fluid management for surgery. All right, you want to push the SVR, not the Starling curve. You want to keep it normal, 8 to 1,300. Hemodilution is the enemy. Over-hemodilution is the enemy. It leads to organ edema and organ dysfunction. That leads to morbidity and mortality. But more so, hemodilution creates a dilutional anemia and a dilutional coagulopathy, and that leads to blood products. And that has its own morbidity and mortality. So you want to give as little volume as you needed, and you want to keep the patient tight until you can ultrafiltration post-bypass. You can also hemoconcentrate during the case as well. When you're given large doses of Plege, you got to get that clear fluid off. So now we're talking about the surgeon. You want to communicate clearly during the case with the surgeon, and him too. He's got to communicate clearly with you, and he's got to work diligently. There's a lot of surgeons that want to talk about their kid's basketball game or their skiing trip or whatever, but when the clamp's on, you really should just be working diligently, moving along quickly. The surgeon in the beginning should have patience with the perfusionist while they're wrapping. You want to refrain from cooling as much because it hurts and stuns the platelets. You want to use meticulous surgical technique. It should always be employed throughout the entire surgical procedure when there's bleeding. So whenever there's obviously surgical bleeding, the surgeon should stop, tie down or cauterize the area to reduce the waste of blood. And of course, always, if you have microwear, I say stop and fix it. Microwear, microbubbles. Remember that a transfusion of any allogenic blood product is an organ transplant, but we don't treat it like an organ transplant. You need to think of it like that. It's not just another medication without side effects. You need to treat everybody, every patient, like it was a Jehovah's Witness. Now the perfusionists. Perfusionists need to condense their circuits safely down. Most perfusionists are around 1 liter to 1,400 mLs now. If you get it much smaller than then, you run some risks of safety and reaction time for air and your circuit going dry. So again, you want to make sure that you safely condense your circuit. You can calculate the post-dilutional hematocrit, protein levels, and call it osmotic pressure values before you even go on bypass. You want to wrap and vap both sides of your circuit with the help of anesthesia and the surgeon. This is not only proven to be very effective in many studies, and it's very cost effective as it costs nothing. You want to add albumin, osmotrol, to increase the colosmotic pressure to diurese the patient. You want to limit the cell washer to the pre and post heparinizations periods. Use the pump coronary sucker during heparinization period to preserve frank autologous whole blood lost outside the heart, inside the pericardium, and return it back to the patient's circulation. A waste sucker should be kept in the field for undesirable shed blood and irrigant solutions. Or if you want, you can use a cell washer for that too. You have to have on-site coagulation monitoring like TEGs, Sonoclot, heparin concentration determination. The HepCon is a great one. These are all essential tools in determining hemostasis. You want a targeted pharmacotherapy, so antifibrinolytics, desmopressin. They're all integral part of to prevent transfusion of donor allogenic blood products. Hemoconcentration. Hemoconcentrators should be considered for use on almost all cases with this excessive fluid administration, especially large doses of the single-dose pledge stuff. You want to eliminate undesirable byproducts, including antiplatelet meds. You want to concentrate the patient's red cell mass and plasma proteins during the case as well as after the case. And again, once off bypass, salvage the circuit with ultrafiltration so you don't waste any of the patient's own viable and vital blood fractions and components. The big bang of hemofiltration, the re-beginning of a new era. So way back in 1991, NIAC wrote a paper about muffing with kids and ultrafiltration. So what does it do? Of course, we all know it removes selective plasma water. Anything that's less than 50K Daltons, that all comes off, including Integralin, ReaPro, Agristat, Plavix. Those things can help come off. It conserves obviously all your blood products, your platelets, your clotting factors, albumin, but it also reduces aflatoxins, C3A, C4A, C5A, IL-1, IL-2, IL-6, IL-8, TNF-alpha, myocardial depressant factor, and bradykinins. It improves organ function, cerebral oxygenation, pulmonary compliance. It reduces postoperative blood loss for transfusions. And again, removes platelet activating factors. It's an adjunct to diuresis of the patient of fluid retention. So what did NIAC say? He said, this is something that works really great for a prospective randomized trial. He said, why are we throwing away this blood from the circuit at the end of the case when the platelets are still working? This was a study I did with one of the universities, and it just looked at how much volume comes off with an ultrafilter. And these are adult ultrafilters, and it's anywhere from 150 to 173 mLs per minute at 500 a flow. So when we're processing end cardiopulmonary bypass circuit blood, there are three methods for getting that volume back to the patient. You can directly put the legs down, dilate them out, and tank them up. Give me 100, give me 100, give me 100. You can cell wash it, or you can ultrafiltrate. And of course, when you look at this graph, on the left-hand side, you can see the different types, direct, cell washing, and ultrafiltration. And on the right across the top, you can see the percentage hematocrit, the platelet count, the fibrinogen, and the percent of clotting factors. Cell washers do a great job at saving red cells, but they're not so much the other stuff. Direct infusion, of course, has a lower crit and more diluted blood. Ultrafiltration, when concentrated, it gives you a better crit. It gives you a better platelet count, obviously fibrinogen, and a larger percentage of your clotting factors. And again, here's the ultrafiltration hemobag versus cell washing. The issues are on the left, and then you have the two columns. So you have clotting factor preservation is better with ultrafiltration. The protein fibrinogen preservation is better with ultrafiltration. Avoiding allogenic transfusions is better with ultrafiltration. Both they concentrate some of the drugs, but cell washing definitely removes more heparin. The platelet, RBC, WBC preservation is better with ultrafiltration. You can remove some cytokines and aflatoxins as well with cell washing and ultrafiltration. Contamination is not with ultrafiltration, but believe it or not, because that cell washer wand is sucking air the entire time throughout the entire case that it's on, every time you check, you'll have bacteria in the cardiotomy reservoir. So fat removal, hemobag will not, or the ultrafilter will not remove fat like a cell washer would. But cost savings, again, cost savings are decreased with avoiding allergenic blood products. And of course, some cost savings with reduced allergenic RBC use. So this is the product, a hemobag. And again, it's ultrafiltration. Here's a diagram of how it's used. And that picture is, remember, this is supposed to be a 2-liter bag, but we blew it up just to see how much volume we can get in it. And in an emergency, you can definitely get 2.4 liters in it. So the hemobag is an easy way for perfusions to save extracorporeal circuit blood quickly and easily. It also keeps your circuit safely primed in case you have to crash back on. The process takes 8 to 10 minutes from aortic to cannulation to anesthesias infusing back this powerful unit into the patient. It allows you to hemoconcentrate both during the case and at the end of the case. So it's got a dual use. The end product is a hyperoncotic autologous whole blood packed with viably functioning platelets, clotting factors, albumin, plasma proteins, and RBCs with no morbidity or side effects. Remember, this is your own blood. It's got every key to every lock in your body. You're not going to have a problem from your own blood. So I want you to remember this picture. We call it the big picture of whole blood. And you can see red cells, white cells, platelets, and plasma. And that's what you have in your body. So here we're talking about before you go on bypass, you have 2 separate circuits with 2 different volume types. The patient has the whole blood, and generally the circuit has crystalloid fluid. But when you go on bypass, now you have 1 circuit with the same volume type. It becomes a diluted whole blood at this point. When you come off of bypass, now you have 2 circuits again, 2 separate circuits, but now it's exactly the same. Whatever's in the patient is in the circuit. There's no difference. The same platelet count, same fibrinogen count, everything is the same. There's no difference. How you process that circuit changes the outcomes when fluid overload is an independent predictor of mortality. Remember, there's 3 reinfusion methods: direct reinfusion or tanking the patient up, cell washing, or ultrafiltration. And you do this at the end of the case. So fluid shifts in microcirculation, call it osmotic pressure, lymphatics, and organ edema, they are the new frontier for improving patient outcomes by teams in cardiac surgery, along with hemostasis when dealing with diluted blood. Fluid overload is an independent predictor of morbidity in cardiac surgery patients, as well as a direct trigger for transfusions, which carries its own evidence for morbidity and mortality. The ideal end product given back to the patient would be autologous blood, concentrated autologous blood with a high crit, high albumin, high total protein, high platelets, normal electrolytes. There's not like it has a high K or an out of whack sodium, normal electrolytes. Very high fibrinogen. The process is very quick, 8 to 10 minutes. It keeps the circuit safely primed in case you need to crash back on. And again, it's all autologous. The patient gets their own blood back. So again, it's a 3-step process. You want to come off bypass. You want to fill the hemobag off the field of surgery from the aortic cannula. They have a line that goes off the field. You hemobag to the hemobag. You fill it that way. You want to concentrate that. Multi-pass hemoconcentration, so it takes 8 to 10 minutes, and then all you have to do is give it the anesthesia. They spike the spike port body, and they put that volume right back into the patient. So what are the changes, the functional changes in whole blood? What we did is we did between 8 and 11 patients, and we sent these to ITCC at University of Pittsburgh, their blood laboratory, and we looked at the pre-processing in blue, the post-processing in green, and the percent change. And of course, the p-values are all great. So the ones we all hone in are the INR, the fibrinogen. Some people look at factor 7, von Willebrand, but platelet count and platelet function, those are really important. And again, as you can see, from the blue to the green, everything was statistically improved. And you can see in this diagram as well, everything in a red box is a normal value. Pre-processing, you can see everything except for the factor 7 and the factor 9 was out of whack. And then after concentrating, everything came back into the normal or exceeded the normal level. So what's the next evolution in autotransfusion for extracorporeal circuits? Ultrafiltration has the benefits, as we said, of quickly concentrating, saving everything for the patient. So again, improved coagulation. Pre-op on the left-hand side, intra-op, everything kind of goes out of whack. But post-op, after you've returned this ultrafiltrated blood, everything almost comes back to baseline normal. You want to see as little chest tube as possible, around 1 to 300 mLs, and a lot of it can be just serous fluid. It doesn't have to be red cells. So the goal here is to have as minimal chest tube drainage postoperatively as possible. So Jeff Riley and I wrote this paper back in 2007. This is an online autotransfusion waste calculator paper. So people could go online, even during a case, and enter their values into this waste calculator, and it would tell you how much volume you were discarding and what it would cost. Now, granted, you would need, back that up a second. You would need to know from your blood bank how much your platelets cost, your albumin, your fibrinogen, all those things. But everything in the green is something that you can add in. Everything in the yellow is a calculation. So you can see that if somebody was to process 2 liters with a crit of 25 coming off pump, platelet count of 140, protein count of 4, and a fibrinogen level low of 120, you would be throwing away about $4,200 worth of autologous blood products to the waste bag if you cell wash that blood. So postoperatively, this is important. The nurses and the ICU care team, you want to make sure you have normothermia. You don't want patients shivering. You want to make sure normothermia, they clot better. You want to do microsampling as little as possible. You can rely on these oximetry devices now. They're amazing. The company called Massimo has one that's a sticker that they're getting approval for in the OR. And you can slap this on the patient's thigh just like you would for a balloon. You can also have the digital one or the one you put on your ear or whatever. But those tend to, when you drifting or cold, they don't work as well. They're amazing. They are absolutely amazing. You can actually get an arterial waveform off of these, and it will tell you your hemoglobin, and it's very, very accurate. I tried it myself, and it was dead on. So again, careful and judicious use of volume is needed. Pressors instead of volume, colloids instead of crystalloids, diuretics if necessary. And here's a key. You want to extubate as soon as possible. And why is that? Because they're certainly not going to let you out of bed unless you're extubated. So you want to extubate as soon as possible. Lastly, no drive-by transfusions from on-call staff. When I say drive-by transfusions, what I mean is in the middle of a night, they call up the resident. He's been busy. He's been running around. And they say, hey, Dr. Jones, Mr. Johnson's hemoglobin or his hematocrit's down to 21 now. And without even getting out of bed, he just says, give him 2 units of red cells. He never got out of bed. He never went to see why his crit was down. That's called a drive-by transfusion. So you want to have no drive-by transfusions. Lastly, hospital administrators. You want to get to know your hospital administrators on a personal basis. You want to suggest benefits of a blood management program. You want to get them involved as well. You can look at consultants. Now, 3 of these consultants were doing really well, but there's only one left now, Strategic Blood Management. Those are companies that you can hire to come into your hospital and show you what you're doing wrong, and they'll give you a report. It'll cost you a lot of money, but you'll get the full clean bill. Again, you want to encourage trials of new equipment and drugs, and this is really important. You need to find a champion for blood management. When I talk about being a champion of the big 3, meaning surgeon, perfusion, anesthesiologist, you have to have 2. It can't just be the perfusionist that wants to save blood. It's got to have a surgeon or an anesthesiologist. 2 of the 3, and it goes. 1 of the 3, it never works. So you got to find a champion for blood management. It's easy to show them the facts on how savings for everybody. And if you start saving money for your hospital administrator is going to be one happy camper. You might even get invited to the big hospital Christmas party with the CEO. You never know. So that's it for my first half of my presentation. And Joe, I think you want to take questions when? In the middle or at the end?
At the end, if we may, please. And so, Keith, thank you so much. I was wondering, would it be possible to get Keith's picture up there? Like when he's giving, just some technical question, when he's giving his presentation, can we have a window with him in it like we normally do? Because I know he's coming in on Spike and we can't see Keith, and I'd like for him to be able to join us now too. So if you could make that happen while I do this, let me introduce. He's there, but we don't. Okay, there he is. I see. Hey, Keith, there you are. Okay, so let me while we're doing that, getting Tammy's presentations. I've introduced Tammy, but also now we've been joined by Stephanie and Rodell. Stephanie Ebus and Rodell. Stephanie is currently the manager for Houston Extracorporeal Technologies here in Houston. And of course, she's been a panelist on our program and a presenter and a contributor to our Perf web series. Thank you very much for that, Stephanie. She has been certified since 1999, if you can believe that, from the Ohio State University, and was formerly employed in Canton, Ohio, before joining us down here in Houston, and at the St. John Health System in Detroit. Welcome, Stephanie, and thank you so much for joining us.
Thank you.
And then next to her is Rodell Ebus. Now, I know they look like brother and sister, but they're actually husband and wife. Rodell is currently an ACE staff perfusionist. He wrote that for HET here in Houston, and also it says former panelist, but he's contributed greatly to the Perf web series as both a presenter and a panelist, and we thank you so much for that. Rodell, thank you for coming tonight too, taking your Friday evening with us. He has been certified since 2002, graduated from the Texas Heart Institute School of Perfusion. And he has, before coming to HET, he was with the St. John Health System also. In fact, that's where him and Stephanie met, as a matter of fact, up in Metro Detroit as a staff perfusionist. And he was also a clinical instructor for the Rush University School of Perfusion Technology and the Ohio State University perfusion program. I wish that was still in existence. That was really a great program. Stephanie, that's where you graduated from, was Ohio State. You're an OSU grad. I know. That was a really great program. I hated to see it go. So with that said, I think we have Miss Tammy's presentation ready to go?
We do.
Okay, good. So let's go ahead, and I'm back on this, and Miss Sparacino, the floor is yours.
Thank you. Good evening, everyone. Thank you for joining us. I am certainly not an expert in blood conservation the way Keith is, but it is a growing interest of mine, and I'm happy to be here presenting this talk. Blood transfusions, where we began and where we should be going. Okay, our earliest history. I found a very amusing story that perhaps the earliest attempt was chronicled by an Italian humanist, Stefano Infessura, documents an attempt in 1492 that human blood was administered by mouth to Pope Innocent VIII.
Lovely.
It was unsuccessful.
Lovely.
The Pope and the 3 young boys that were the donors died. Now, there's much dispute as to whether or not that actually occurred. It is documented, but many people believe, since the idea of circulation of blood had not been discovered yet, that it's unlikely. Moving on to when we actually learned that blood was a circulating thing, William Harvey in 1628 studied beating hearts in animals, and he figured out that the heart was not just making blood, that it was actually circulating it around the body. Many of the predecessors believed that blood was created by the digestion of food and used up by the tissues. His interest in his discovery in circulation increased interest in animal experimentation and trials to be conducted. The first human success was with animal blood. John Baptiste Denis I'm not sure if I'm saying that correctly, in 1667, he gave a small amount of sheep blood to a 15-year-old boy, and it was successful. He had a few other successful attempts as well. The idea is that it was probably successful because a very small amount of blood was given. That created a lot of excitement, and lots of people tried to start doing this, but because of the different reactions that occurred and many causing deaths, within 10 years it was prohibited and people kind of moved on from that. Richard Lower studied blood volume with experimentation on dogs. He used to like to get dogs and connect them together and pump one blood from one dog into the other until the dog passed out or whined. So he learned a lot about that a certain amount of blood volume is necessary to continue life. All right, the first direct human donor was attempted and successful by James Blundell in 1818. This is the diagram that was submitted, or rather the illustration that was submitted with his published article. He gave a husband to wife blood transfusion for postpartum hemorrhage, and he would continue with human trials with 50% of his trials being successful. Just some highlights. There's many modern advances that got us where we are today, but here's just some of the ones that I thought were the most interesting. With antiseptics becoming a thing, Joseph Lister in 1867 greatly increased the success of many things that we do in medicine. Blood transfusions are no exception. Saline became a blood substitute in 1884, and if you can believe this, I found somewhere that said prior to that, milk from cows had been considered a blood transfusion substitute.
Very good. Very excellent.
Blood types were, of course, discovered in the early 1900s. First by Carl Landsteiner, he discovered the first three, and then by his colleagues De Castello and Strulli, I'm not sure if I'm saying that correctly, in 1902 with the fourth type. Typing and cross-matching was developed by Odenberg in 1907. And then the anticoagulations developed sodium citrate in 1914, which of course was going to be a real advance for the storing of blood. Albert Holston in 1914 is credited with the first indirect transfusion. And Richard Lewisson in 1915 first introduced the indirect blood transfusion in the US. Then we're going to move up to like the 1940s, and we see something that stayed with us for a long time, and actually we're still seeing it today, is the transfusion trigger, where someone's decided that we have some number, and once that number is no longer been met, that it's time to give blood. And that was determined to be hemoglobin less than a 10, and that was preoperative. Was widely followed and accepted even after many studies came out, and it was determined that it was probably an ineffective guideline to follow, but word of mouth had already done what it does, and everyone just followed it anyway. Mm-hmm. Today, in 1988, this is the criteria that first changed the transfusion trigger. And here's a quote. 1988, the NIH Consensus Conference reconsidered the de facto standard criterion for perioperative blood transfusions and added a consideration of the patient's clinical condition. But even this recommendation was based on limited data. The revised guidelines state that most patients will not need perioperative blood transfusion if the blood hemoglobin level is less than or equal to 10, but probably will require a transfusion if the level is less than or equal to 7. This guideline stresses that the decision to transfuse also depends on clinical criteria such as the duration of anemia, the patient's intravascular volume, the probable extent and continuation of blood loss, and the probability of massive blood loss, various coexisting medical factors. Hemoglobin minimum level is something that has become quite popular to talk about now, although there's been many studies over the last decade where they're looking at restrictive versus liberal transfusion strategies. And there's a little bit of variation in what restrictive is and what liberal is. But generally speaking, a restrictive program looks at hemoglobins 7 to 7.5 for intraoperative and postoperative as an acceptable level. So unless you reach those below those levels, then no need to transfuse just on that alone. The liberal program looks at 9 to 9.5, some even say 10, getting back to that original trigger, that intraoperative, postoperative, or 8.5 if they're postoperative but not in an ICU. Now they say acute coronary syndrome would have a little bit different parameters, being around 8, but it's only suggested, and there really is not enough data to support that it is definitely necessary. In fact, many believe that it's no more effective than a 7 guideline. Restrictive recommended for most stable patients, including the critically ill. The clinical practice guidelines for AABB were developed from a study that did reference libraries, conducted a literature searching a randomized controlled trials in 2016. The purpose was to determine hemoglobin threshold for red blood cell transfusion in adults hospitalized patients. They looked at over 31 trials with over 12,000 patients between 1950 and 2016. They compared restrictive with a 7 to 8 hemoglobin trigger to a liberal 9 to 10 hemoglobin trigger. They found restrictive groups did not have more adverse clinical outcomes than the liberal groups. Here's the areas that they looked at and considered adverse clinical outcomes. They tracked 30-day mortality, MIs, cerebral vascular accidents, rebleeding, pneumonia, and thromboembolism. They also looked at fresh blood and whether or not standard issue blood or immediately fresh blood, although I didn't see where that was an exact time period, whether they affected clinical outcomes. They looked for that particular part of the study, 13 trials with over 5,500 patients from 1948 to 2016. And they compared, again, the fresher blood to the standard issue blood. And from those results, they found no difference in clinical outcomes. Now, we all know that blood is a supply and demand problem. According to the Red Cross, the daily need for red blood cells is 36,000 units, 7,000 units of platelets, and 10,000 units of plasma. An annual need of 21 million blood components, and that's what's administered. Donors are estimated about 38% of the U.S. population is eligible to be a donor, but only about 3% actually donate. We've all heard about the cost. Now, I found several articles that limit the cost to about $210 per unit, but many of them said there's variation depending on geographic location, and larger teaching hospitals tend to get kind of a high volume discount versus smaller community hospitals. Thought this was very interesting. Small changes can be so impactful. In 2009, Stanford Hospital and Clinics decided just to do one small thing. Every time a doctor approved a blood transfusion, he had to review the transfusion guidelines as a part of the approval process. Just the act of reading that before he did his approval or her approval, 24% decrease in transfusions that year, with an annual savings of $1.6 million from their annual budget of $7 million that's set aside for transfusions. Associated negative outcomes. There are many studies that have been done on this. I, in particular, looked at the Bristol Heart Institute study of 2003. It was a retrospective cohort study. The patient analysis and tracking system, the hematology lab database, blood bank database, and the UK population registry, they were all linked together so that they could get all the information that they needed to track many parameters. But it was I thought, a very thorough manner to look at all the parameters that they'd like to look at. They analyzed data from 1996 to 2003. It included over 8,700 patients. 8,500 were actually included according to the criteria. What they found were infections increased with transfusions, ischemic events increased, hospital stays increased, early complications increased, and mortality increased, 6 times higher in the first 30 days. What we need to be moving to is an idea that we can do bloodless surgery. There are a lot of cutting edge programs out there. Johns Hopkins has one in particular where they really have an attitude that that is something that's possible. I thought this diagram that I found was a really neat thing. It's very simple, but it also is very eye-catching that it starts in the very beginning. Just as Keith said, it's going to start weeks before surgery is even done. There's going to be a lot of open communication with the teams that are going to be involved in the care of the patient and the patient themselves, so you can find out, what will they accept? Are they a Jehovah's Witness? If they're not, shouldn't we be treating them like a Jehovah's Witness anyway? That is really an idea that we should have and we should be doing. We manage to do successful surgeries on people that don't accept blood products very well and have for many years now. That's how we should be treating all of our patients that we see. Our solutions, we need to get everyone involved. Education is probably the biggest thing. Everyone on the team needs to be a part of what's going on, understanding what blood conservation can do for their program. It's better for the patients. It saves the hospital money. And also developing a blood conservation team. Your hospital or your practice may already have something like that in place, but get your actual clinicians that you practice with involved, or start your own, and then you can report back what you're seeing, in the surgery, in your ECMOs, all of those sorts of things. Everyone who is in the surgery suite or in the ICU suite need to be a part of it. Track and review your clinical practices to determine blood usage and compare them to benchmarks. You'll never know how good or bad you are if you don't start tracking. My citations, and until we can do this, we got to figure out how to do some blood conservation. Thank you.
Very good. Excellent.
I feel like I should clap.
Excellent. I think we can clap. We can. That was an excellent presentation. Okay, so are we going to be able to, that was a very good lecture. And Keith, yours too. Are we going to be able to bring Keith up with his next slide so that we can see him while he's giving the lecture?
No.
And no? Okay. And so that's not going to happen. So Keith, why don't we go ahead and we'll have you go ahead and do your next lecture, and then we'll open it up to discussion and call it all that. And I got to ask, are you there, Keith?
I'm here.
Oh, good.
I
was going to ask, okay, look, when was that picture of you taken that we're putting up? Okay. It's black and white, number one. I mean, was that taken before the advent of color cameras, or what's the deal?
Yeah, actually it was. No.
I have no doubt. Okay.
I think it was during my first job, which was at Hopkins in 1989.
Yeah. Okay. So,
It's a great picture.
It is.
Nice.
It's a great picture of how you used to be. Yes. So eventually everyone is going to see you. Oh, there you are again. Okay. I'm going to take a new picture of you, Keith, myself. Okay. And because we need that. All right. So you ready to go with your next presentation? And
I
then,
am.
Mm-hmm, and then, hey, Magic, we can get that on here too, so that way I can see. Okay, Keith, the floor is yours, sir.
Okay, thank you again, Joe. Okay, so there we go. Again, my disclosures. So this part of the talk is going to be more on the physiology of fluid volume management. So as you can see in this picture, you have circulation and you have lymphatics. And of course, we have, two circulations. We have systemic circulation and a pulmonary circulation. So around the body to all the organ systems. And of course, where the volume goes and under what pressure, everything is hydrokinetic. So from arteries to veins, They're very similar, except that the veins have semilunar valves and the arteries have more of smooth muscle, a thicker smooth muscle that can contract. So this is the epicenter of fluid balance and life itself. Everything takes place right here in the capillary bed. The green there, that's the lymphatics. And of course, I don't have to explain the red and the blue. So what is microcirculation? Well, there's so much here to go through that I just want to have the slide up for a little bit. But of course, we all know it goes from arterioles to capillaries to sinusoids to venules. And that's called the thoroughfare channel. So even though blood is, going through your arteries and veins all the time, it's not all going through capillaries all the time. Sometimes the precapillary sphincters are, open, and you have blood going into the capillaries. And sometimes the precapillary sphincters are closed, and there's no blood. It goes right from an arteriole to a venule. So down towards the bottom there, as I said, there are some times when blood is diverted to other parts of your body that need it the most at a particular time. For example, when you're eating a meal, it's diverted to your stomach for the digestive tract. Or you walk outside and you see a tiger and you run like crazy, the fight or flight kind of thing. And your cardiac output goes from 5 liters to 20 liters per minute. So again, the different sizes of the capillaries are the thoroughfare channel is down there at the bottom. And again, here's a better perspective of what sizes we're talking about when it gets down to the microns. So arterioles, they have the precapillary resistant vessels. They're 10 to 50 microns, and they're surrounded by smooth muscle. And that creates our SVR, our vascular tone. So it's richly innervated by both alpha-1 and alpha-2. It's a major site, as I said, for regulating the systemic vascular resistance or vascular tone. And the primary function, again, is the autoregulation of flow going in and out of the capillary beds, where you wash out the metabolites and you drop off the oxygen and the nutrients. So again, this is just a representation. Your normal SVR should be 8 to 1,300 dynes per centimeter square. The bottom left is vasoconstricted, and the bottom right is vasodilated. So what are capillaries? Well, basically, they're thin, and it's a thin wall that are composed of endothelium, a single layer thick, that are overlapping flat cells. And this is where everything takes place in the capillary bed, where again, oxygen is dropped off, CO2 is picked up, nutrients are dropped off, waste products are picked up. And again, we talked about the precapillary sphincters that allow either flow to go through or not to go through. Capillary sizes are so small that the red cells line up almost in a straight line as they go through single file. So 5 to 10 microns in diameter. And of course, you have the tonicity of fluids. So you have the osmolarity, which is the ions is the osmotic force, the proteins are the oncotic force. A hypotonic cell, cells placed in hypotonic solution swell. Isotonic, which is ideal. And then hypertonic, cells that are placed in a hypertonic solution shrink or crenate. And this is just a representation of that. You want to be isotonic, not hypertonic or not hypotonic. So albumin is really, really important. A lot of people don't seem to think it is. I think it's one of the best things. If you're going to add something to your pump, I think the most important thing you can do is add albumin to your pump. And then, of course, don't cell wash it all away at the end. Save it. Concentrate it, give it back. So normal concentrations are 3.6 to 5.2 grams per deciliter squared, and that's a colloid osmotic pressure of about 20 torr. When levels are below 3.2, it's generally considered dangerous. You got to remember that serum albumin is increased in dehydration, it's decreased in malnutrition, chronic liver failure, malabsorption, SLE, burns. The thing you really need to know here is that albumin is a function of nutrition. If you have a good nutrition, you're going to have a good albumin level. And if you don't eat or you drink more than you eat or whatever, we used to see this in the VA where people drank more than they ate. They always had a very crappy albumin level. And when they got on bypass, they sucked up volume like a sponge. So the key here is to have a good albumin level. Try to keep that colloid osmotic pressure. And again, the goal here is to keep it intravascular, not extravascular. So when third spacing is identified as a low protein level, albumin may be administered to regain fluid lost into the interstitium. When injecting intravenous 50 mLs of 25% albumin, you'll get about 175 mLs of additional fluid back into circulation within 15 minutes. So again, let's go a couple more things about albumin. It's the most abundant plasma protein. It's about 69,000 Daltons. It offers about 80% of the colloosmotic pressure. Normal colloosmotic, again, is 18 to 22. Hemodilution really drops this. One of the big functions it does is it transports the sequestration of bilirubin, but also it transports fatty acids, hormones, vitamins, enzymes, drugs. Some of the big ones are warfarin, diazepine, dig, NSAIDs, midaz, thiopental, and many, many other drugs are all carried by albumin. So the one thing that I don't think a lot of people realize that it's an antioxidant and it's a free radical scavenger. So it inhibits endothelial cell apoptosis and influences the microcirculation by modifying the capillary permeability by protecting the glycocalyx. And we'll get into the glycocalyx a little bit more in a minute. The other thing it does is it's buffer an acid-base balance. It actually fixes the hydrogen ions. And this is one thing that people need to know. There's no maximal dose of albumin, and it has no effect on hemostasis.
That's right.
So when people say, oh, you've given so much, it's screwing up my coagulation. No, it doesn't. So again, fluid movement between compartments, as you might have seen this before a little earlier, it always wants to find its equal level. So if you have a high concentration of water and you have a low concentration of water, the fluid and the water want to equal themselves out across a semi-permeable membrane. And that's Starling's law as well. You have the osmotic pressure and the oncotic pressure that are fighting against the hydrostatic pressure. So here's going to be something very interesting. This is, if you look in the very middle between these sets of cells, we'll call it the capillary bed. These are single cells, single layer of cells, endothelial cells. And in between each cell is a space or a channel. In the middle, you have the vascular lumen. So you have vascular lumen on the inside, interstitial space on the outside. But this is the gatekeeper. You see those crazy hairs? That's what it's the gatekeeper, the glycocalyx. The glycocalyx is something that everybody has to get to learn to know. So as you can see, it's kind of, there are different pictures here where you have the glycocalyx and some other pictures that we'll get into where it's missing. The glycocalyx helps to keep fluid intravascularly and protect it from going extravascularly. So the endothelial glycocalyx is a gel-like layer that coats the entire inner surface of the endothelium throughout the entire vascular tree. It's less than 100 nanometers thick. It's made of negatively charged carbohydrate polymeric glycoproteins that are plasma soluble. It's produced by bacteria, epithelia, albumin, and other cells. If you think of it as a non-stick Teflon coating on the luminal endothelial surfaces, what's interesting is I think everybody in the audience has picked up a fish before and it's got that slimy outer layer. That's like the fish's glycocalyx. If you were to scrape off that slime layer of a fish, it would not survive. It's protecting the fish. And if you slough off or scrape off, through sheer stress, the glycocalyx, you're going to have free movement, and you're also going to have white cells and platelets start to adhere to the endothelium. So the again, it's very fine hair-like structures that ultimately they regulate nitric oxide release, and it helps to protect and regulate from leukocytes and platelet adherence. So it helps with the vessel wall for homeostasis and equilibrium. So here's a couple more pictures that I'm going to show you about the glycocalyx. There's one looking straight down the middle. There's another one on the right. It inhibits platelet adherence and coagulation, and it regulates inflammation by preventing the leukocytes adhering to the vessel walls. It shields the vascular walls from direct exposure to blood flow, shear stress, and shear stress. Basically, that's what you want. Shear stress is what sloughs it off. But again, it's a vascular perimeter permeability barrier. A couple of last pictures here. On the left, you have an intact glycocalyx. You can see those hairs. And on the right, you have it's missing, and you have white cells that are starting to get through the endothelium and platelets. So again, all of these set the stage for a thrombotic event as well. So the glycocalyx can get damaged from shear stress, decreasing the nitric oxide availability and oxidative stress, a leakage of macromolecules, as we said, platelets and white cells. These damaged glycocalyx areas increase permeovascular edema, leading to leakage of fluids and proteins, which causes tissue damage and loss of capillaries. Last one, the glycocalyx. Actually, I don't think it's the last one. So hypoxemia actually will also help to remove the glycocalyx. So you want to make sure you always have a minimum level. Don't get to the minimal levels of oxygenation, or that could help to degrade the glycocalyx. But it's primarily fluid shear stress that strips it off of the endothelium. And that can be from like a very tight capillary bed when they say pump off, pump on, pump off, pump on. I had a surgeon that did that all the time. You got to go slow. You can't go fast. When you go pump down, go slow. When you come back up on flow, you got to go slow. Otherwise, you're going to be shearing off the glycocalyx. Another thing would be a large white cell that was in a capillary bed. And then you did pump off and you did pump on, and it just, when it went pump on, it sheared off the glycocalyx. But whatever the stimulus is, shedding the glycocalyx leads to a drastic increase in vascular permeability. This permeability enables the passage of macromolecules and other harmful antigens, leading to third spacing edema, and organ dysfunction. So this is the last slide. And on the left, you'll see the hair-like structure, and it's what we call homeostasis or an equilibrium. Everything's going well. You're not having platelets or white cells, and you're not having fluid go massively extravascularly. And on the right side, you have the abnormal. It's been sheared off. You have leaky capillary beds now, and you're starting to get platelets and plasma, white cells, to adhere into the tissue beds of the capillaries. So there's 4 types of capillary beds. We've all been taught this. You have your tight, continuous, fenestrated, and discontinuous in different parts of your body everywhere. And this is just another representation of a continuous, a fenestrated, and a discontinuous capillary bed. So how do fluid shifts happen? Well, we discussed this a little earlier, but we'll go over it just a couple more times, a couple great visuals here. So you have capillary pressure, and you have interstitial pressure. You have plasma colloidosmotic pressure, and you have interstitial fluid colloidosmotic pressure. And here's another one where you have hydrostatic pressure wanting to push fluid out, and you have osmotic pressure wanting to pull it in. So on the left side, you can see arterial end. It's under hydrostatic pressure, where it's going to push out almost everything except for the red cells in the capillary bed. And then on the capillary bed end, in the venule side, under colloidosmotic pressure, all those things are brought back in. So again, you're pushing out oxygen, or you're delivering oxygen and picking up CO2, but you're pushing out into the tissue bed all the nutrients that you need, and you're picking up all the waste. So pushed out on the arterial end under hydrostatic, pulled back in on the venule side. And this one last one is a great representation as well. So the green is the lymphatics. That's the body's natural sewer system. On the left side, you have the hydrostatic pushing the fluid out. It comes in contact with the cells of the body. And then on the right side is the venule side, or the osmotic gradient, that pulls the fluid back in. Now, what happens when you don't have a good colloidosmotic pressure? Well, normally that extra volume is taken up by the lymphatics, so the body's natural sewer system. So you may not have a good albumin level, but you're counting on the lymphatics to help pick up that extra fluid and return it back. Here's the kicker, the lymphatic system. There's a lot to read here, but what I've highlighted here is the most important thing. Lymph is not pumped through the body like blood is. It's moved predominantly by contractions and movements of skeletal muscles. So what is the one thing that every single patient has in common when they go to surgery? Mm-hmm. They're not moving. We've paralyzed them, so essentially we have paralyzed the lymphatics. Now, if you do not have a good colloidosmotic pressure and your lymphatics are not working, you're going to have organ edema and tissue edema, because that fluid is not going to be able to find its way back. And again, this is the lymphatic system. If you start at the bottom, you see the capillaries. It works its way up, all the way up to the left subclavian, where it's returned to circulation. The loss of protein and lymphatic flow. This is a slide from Dr. Valeri up at Naval Blood Research at Boston University. He's since passed away, but this is about 15 years ago. And he took 4 students. And he was testing them where he would plasmapherese them over a period of 8 days. And as he took off more and more proteins, their lymphatic flow increased to make the difference. Now, you and I and everybody else in the audience has lymphatics of about 2.4 liters a day. Every day, 2 to 4 liters a day is being returned by the lymphatics. But if you have a low protein, lymphatics really kick it up a notch, and they start to pick up. And as you can see, it can be up to 10 liters a day of low protein situation. So there's 4 causes of edema: obstruction, permeability, plasma protein reduction, and capillary pressure. We're going to focus on plasma protein reduction. Reduction in circulating plasma proteins, especially albumin. Remember, liver dysfunction, malnutrition, or acute alteration in fluid status, which is something that we do. Albumin attenuates the movement of fluid out of the intravascular space and into the interstitial space. And as I said to you earlier, it's the number one as far as plasma colloidosmotic pressure of all the proteins that we have. It's albumin. It's about 78 to 80%. So fluid overload is an independent predictor of mortality. And this is from that Chappell article, A Rational Approach to Perioperative Fluid Management. I would suggest everybody read that paper. It is so good. But what he showed was if you came into the hospital and you put on 10 extra pounds intraoperatively, you've increased your mortality, not morbidity, mortality by 10%. Mm-hmm. And if you increase your body weight from pre-op to post-op by between 10 and 20%, you've increased your mortality by 20%. And then anything over 20%, and again, this is not treated with diuretics or trying to get the volume up by ultrafiltration or whatever. Untreated, anything over 20% is 100% mortality rate. And that's, again, in that Chappell paper that you should definitely read. So hypoalbuminemia leads to third spacing. Worst case scenario, anasarca. Joe, you were the ones that told me about anasarca. I always saw it. I didn't know it had a name until you told me about it. But basically, it's generalized edema, swelling, very low oncotic pressures. Again, levels below 3.2 albumin are considered dangerous. So, and I've already mentioned this earlier, if you give 25% albumin, 50 mLs will bring about 175 mLs back into circulation. So perfusionists have tools to minimize hemodilution. The big ones, obviously, albumin, mannitol osmotrol, Lasix, and hemoconcentrators. Those are our tools to help fluid management. So we talked about this before. The 3 types of methods of ultrafiltration, or we didn't talk about this, but I'm telling you now, there's 3 methods of ultrafiltration. The traditional muff, which requires, cannulation to stay in, prolongs OR time, requires a combination of many team members. You have to have patience, and sometimes it requires inotropic support. Then you have homemade or single pass versus multi-pass. You can try multi-pass, but most of these people that make up their own things, they can generally not get multi-pass. And then you have the hemobag method. The clinical studies performed here, there is a paper that we did, homemade versus the hemobag, and that was the Delaney paper, which we can show some data from right now. Again, hemobag circuit is easy to use. It's a 2-liter bag. You fill it, you concentrate it, and you reinfuse it. Not only that, but there's no new capital equipment. You're using one of your roller heads. You're doing the hemobag at the end of the case, so you just use your vent pump, or if you don't have an extra pump head, just use your vent pump. So here's the results of that study when we looked at a hemobag method versus a homemade study. And this is when I had a lab at UConn Medical Center. And there were a couple people in the audience when I was giving a lecture and said, oh, I can do that. I can do the same thing. I get the same results. And so I said, okay, I have a lab. Let's do the Pepsi challenge. Any of you 3 or 4 or whatever you want to do, challenge me. We'll do the exact same circuits, the exact same way. We'll count the timing. We'll look at the concentration of blood, platelets, proteins, fibrinogen, albumin, and white cells. So how long did it take, and how concentrated was the blood, and then what was left in the circuit at the very end. So if you look at the extreme left, you'll see the parameters. Then you can see the hemobag values are in blue. The non-hemobag or homemade versions are in black. So if you just look at the hematocrit, the non-hemobag version increased, the change was about 47% versus 126%, no-brainer. Platelet count 36 versus 55, no-brainer. Total protein 79 versus 178, again, no-brainer. Fibrinogen levels increased 44 or 150%, no-brainer. Albumin 80% or 114, and white cells, of course, doubled. On the right-hand side, you'll see what we did. We took 10 circuits, 5 one way and 5 another way, and each time we reduced the amount of volume at the end of the circuit. So we all started off the same volume. So A and B circuit at 500 mLs, A and B circuit at 400 mLs, A and B circuit at 300 mLs, 200 mLs, and 100 mLs. And you can see from the green on the right side, the green started off the same, but at the end, it was a much higher concentration of hemoglobin with the hemobag version. And at the very end, when we drained the circuits, everybody said stop, and we drained the circuits. What blood was left in the circuit? The non-hemobag version always had a crit of about 6, and the hemobag didn't have, it was negligible. And also it was much faster with the hemobag version as well. So here's what you can count on when you concentrate blood with a hemobag. You're going to get the same results almost every time, meaning a crit of about 50. So this was 500 patients done by a program out in Oregon, Salem Hospital, Specialty Care. The average they gave back was 800 mLs of 49 crit blood with a platelet count of 238 and an amazing fibrinogen count of 451 on average. Total protein of 8.2, albumin of 4.7. And when they looked at the clotting factors of 7, 9, 10, and 13, they increased on an average of 260% increase. So what is that 451 mLs or fibrinogen level? Well, if you look at it, that's about 3.7 units of FFP that you're saving, that you would have discarded if you did it another way. Or you can look at it in terms of cryo. It's about 40 units of cryo. So I showed you what was in the bag when you concentrate it. Now I'm showing you what happens when you put it in the patient. So they took 12 patients and they looked at the before they gave the hemobag to the patient, meaning coming off bypass on the blue, and after they gave the hemobag, and they drew the samples 5 minutes after they had given some extra protamine, another 50 of protamine, and you can see the change. Everything was statistically improved. So again, crits were improved, platelet counts improved, fibrinogen improved, the PTT, the PT, the INR all improved. I've also gotten a whole lot of people that say, well, what's the economic, how can you prove this? So most hospitals nowadays have what is called a hospital value analysis review. So in order to get a product into a hospital, you have to prove that it's going to save them money. So this is 100 patients done at a hospital. I'm not going to tell you the name in Pennsylvania, but you can see on the top left, it says intra-op, post-op, and total. So it's RBCs, FFP, cryo, platelets. And on average, the total was about, for each of those 50 patients, was about just over $3,000. And then you look at the hemobag group, the same thing, intra-op, post-op, and total. RBCs, FFP, cryo, platelets total. It was about $1,700 per patient. So it was about a $1,379 savings per case they used the hemobag for ultrafiltration and concentrating the end circuit volume and giving it back to the patient. So the take-home messages, there's a couple, but this is the big one. Discarding functional platelets, clotting factors, and important plasma proteins is counterintuitive to sound ethical and medical practices. It may not be viewed as negligent right now or as malpractice, but that's only a matter of time. We live in a very litigious society. It'll only take one JW patient that got blood products, and they're going to say, did you do everything you could? And they're going to say, well, we could have done this. You can see where this could potentially go. So you want to save as much autologous blood as you possibly can and not discard it. And again, on the left, you're saving red cells. On the right, you're saving everything. Is this still a good idea? Cell washers, they tend to throw out about 280 to 300 mLs per bowl of plasma. Those are the Baylors and the Latham bowl technologies. The CATS is a different story. So again, in the end here, we don't want to throw the baby out with the bathwater. We want to save as much as we possibly can. Everything that's autologous, concentrated, give it back to the patient for stability and homeostasis. Remember, those cells have every key to every lock in your body. You will not have a reaction to your own blood. You may, or you certainly will have a reaction to somebody else's blood products. 100% of the time, you get a reaction from somebody else's blood products. It may be just a little fever, or it may be a drop in your pressure, or maybe long-term, it's something really bad. And worst case scenario, it's wrong blood, multi-system organ failure, death. We talked about trolley earlier in the other presentation. That's the number one reason why people have a problem from getting blood products. So again, saving your own, you're not going to have any problems. All right, for more learning, you want to join AMSEC. You want to take the PBMS certification exam. That exam is being offered now not only for techs, meaning people that do cell washing or platelet gel or bone marrow aspirate. There's an exam for techs called the PBMT, but then there's the PBMS that separates you from everybody. Patient blood management specialist is a higher level, a blood management specialist. So be a leader in your hospital. Take that exam. It's only 100 questions. You can get that in only, there's no case requirement. You pass the exam, you get the certification. You get to renew it every other year, and it's something that you can be very proud of. You want to join the ABB, SABM, Society for the Advancement of Blood Management, and they just merged with the European version of that called Network for the Advancement of Transfusion Alternatives. But all three of those organizations, they're finely tuned international organizations solely focused on better blood management and improved care. So you want to surf the web, you want to read articles, you want to share them with other members of the cardiac team. What I've always felt, what I noticed was if I had a really good article, I put it in the pump room. I didn't ask people to read it. I just left it on the table in the pump room. Everybody ended up reading articles that were left in the pump room, including doctors and anesthesiologists that were sitting around waiting for cases. That's one of the things that perfusionists seem to all have in common. Hurry up and wait. So you get in there and you set up everything and you get all your drugs ready and your paperwork done, and then you got to wait for the mammary to come down, or you got to wait for something else. So if you got a little bit of time, leave the article out. Somebody will read it. Here's a great one. Get on the hospital transfusion practices committee and make a difference. Be the one that's for the perfusionist. Go to those monthly meetings. They usually meet just once a month. You want to find and support a champion. We talked about this earlier. Somebody who wants to change the paradigms of transfusion in your hospital's cardiac team. It can be the surgeon, perfusionist, or anesthesiologist. But I said to you before, it's got to be two of those three or it's not going to work. But you certainly would like to get also the administrator on your as a champion. And again, you have to work as a team that's focused on improvement of patient care. There's a couple more things you can do. You want to visit these sites, noblood.org, Bloodless Medicine Research, SABM I talked about, NADA I talked about, PNBC, which was out of Canada, they've gone defunct now. There's one called the Medical Society of Blood Management, Strategic Blood Management. MyBloodFirst.com is my site, and it's an excellent site for perfusionists. They want to learn more about blood management. Also, you want to get involved. Get as many people as you can to change the paradigm of blood use. And as we've both said, you want to treat everybody like a Jehovah's Witness with a small BSA. For some reason, we can do JWs and not give them blood products, but we don't seem to take it as seriously when they're not a JW. You got to treat everybody like a JW. The bottom line is always the truth. Life is related to blood, and anything else that you can do to save more of the patient's own blood, whole blood, is better than anything else, period. Patients that get transfused with allogenic blood products are exposed to a host of new potential complications. The current data is undeniable, especially in cardiac surgery. No one is exempt from the resultant immunosuppression that people get when they get foreign blood products or allogeneic blood products. Allogeneic. The least diseases, as we said, is TRALI, longer delayed time to extubation and discharge from the ICU, increased risk of morbidity and mortality, both short and long term. Autologous whole blood is jugular for perfect natural homeostasis. And homeostasis means normal. We should do everything we can to conserve as much as we can of this precious substance. Remember, every drop counts. You want to avoid unneeded transfusions, save the costs, and prevent unnecessary side effects. It's in the patient's best interest, and it's the right of all patients. One of our biggest problems, especially in older docs, older perfusionists, is apathy. Don't be apathetic. Be proactive. Make the change. I've heard a lot of people say, well, it's more work, or I got a kid's soccer game I got to get to. It takes too much time. Don't be apathetic. If the data says through peer review that it's statistically better if you do something, you should be doing it. You should be trying it. You shouldn't be complaining. You shouldn't be apathetic. So I had a friend, a Jehovah's Witness friend, and great person. She said, if it's not yours, it's an organ transplant with consequences. So you want to do your best to avoid it. Remember, your decisions affect that patient for the rest of their lives. So do your best to avoid giving transfusions. Again, thank you for your time, and that's the end of this presentation.
Very good. Excellent. I think that deserves an applause, too. Very good. Very good. Okay, and then I think, so I kind of messed up the schedule a little bit. We were supposed to take a short break. So I think, and now I'm starting to feel the effects of my tea. So we're going to take a short break, Keith, if that's okay with you. And then we're going to come back and have our discussion for about 20 or 30 minutes. So how much time do we need for break? We need 15 or 9? 10? 10 minutes. So a 10-minute break, and then we'll circle back, Keith, in 10 minutes. We have to show our obligatory advertisements and all that kind of stuff, the stuff that's keeping the lights on. So if you'll give us 10 minutes, we'll be right back.
Thank you.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low-pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation. and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Okay, and welcome back to the program, everyone. And let's see, where's Keith at? I'll bring him up now. Keith's coming up. Hey, Keith. Uh-oh, we don't have your sound up.
There we go.
Try it again.
Hello.
There you go. You're back. Okay, welcome back, everybody. Thank you very much for that little short break. We've got a bunch of questions. You want to go to a full screen, a full panel view? Yeah, that's perfect. Okay, so I've got questions for everybody. Keith, I want to start with you. You were talking about the delivery when you transfuse saline, how so little of it stays in the circulation, that when you're transfusing the patient and you, especially massive transfusions, you're just pumping saline in to try to get the blood pressure up. What the effect of that 1 liter, you're only keeping 200 to 250, 700 to 750 going into the tissue. So think about 10 liters of circulation if you want to talk about that at all.
Well, obviously, I think I'll get a little feedback here, Dave. I think that what happens is you get that much volume, as Chappelle says, you're in trouble. You'll be anasarchic. You'll have organ edema and organ dysfunction. And everybody knows that organs don't work well when they're edematous. So it's not just your lungs, it's every organ. It's your brain, it's your kidneys, all those things. So yeah, I would hate to have be a recipient of 10 liters of saline.
Yes, well, it happens all the time.
No, I know. That's why you got CRRT.
Mm-hmm. That's right. That's right. Well, how about transfuse something besides saline?
Like albumin.
It would help if you'd add some of that to it. Of course, then you need red cells. So what about you guys? I
have a question related to that. So, Keith, you did talk a lot about albumin, and I had a case where we had a trauma patient that ended up on ECMO, and our cardiac team were definitely pro-albumin on ECMO. We start giving the albumin, we start CRRT, and try to get the third spacing down. This patient was so swollen, had so much volume on board. And the trauma team, the trauma surgeons, were completely against giving albumin because they said there was already the plasma protein leakage. So if we gave more albumin, the albumin would leak, and then we wouldn't be able to get the fluid back in. And that was a big debate between the two, and they would not let us give albumin. Do you have any experience with that or any comments?
Yeah, well, you want to start early with albumin. When I say giving it on pump, I'm talking about not waiting till you're on pump. you want to start right away, because the minute you go on pump, you're starting to third space fluid. So you want to have a higher quality osmotic pressure to stop the movement of the fluid extravascular. And then, like you said, a lot of people will say, well, it's just gone extravascular, and now that it's extravascular, it's pulling fluid more extravascular. No, that's not the case. That can potentially happen, but when you have fluid extravascular, you got to hemoconcentrate it, or you bring the fluid back in intravascular. You got to hemoconcentrate that volume off. Otherwise, it will go back extravascular. You have got to keep that movement in the right direction, which is inward, not outward. And I think that a lot of people don't understand that. I can tell you from personal experience, and I'm sure everyone on this panel has seen this. You've hemoconcentrated a liter, and the crit didn't change. Joe? You guys have seen that, right?
Absolutely.
Yes.
See it all the time.
And what's happened is your higher quality osmotic pressure now, intravascular, is pulling in more fluid from the extravascular. So essentially the crit hasn't changed. You certainly have to hemoconcentrate more to get to the point where I call it the quick. So you get to a certain point where you're actually removed enough that it's going to make a big change now in your hematocrit.
That's right. Well, you have a plasma refill rate.
Right.
So the more you're hemoconcentrating the intravascular blood, then the more, or the higher the oncotic pressure, the faster in the blood, the faster will be your plasma refill rate. So that's why you see that you're ultrafiltrating, but the crit hasn't changed. In fact, your volume hasn't changed. Sometimes your volume goes up in the reservoir. I've seen that happen before too.
True.
But I will say this, and it was a good question, Keith, that Stephanie asked. The one contraindication to albumin administration is a true capillary leak. If you have a true capillary leak, then if you give albumin, it's going to exacerbate an already big problem. And generally speaking, I would say once you have a capillary leak, you're in the bottom of the ninth. You got 2 outs and no one on base, and a blind person's coming to the plate. You got a problem.
I want to say, I agree with everything you said. This particular case was not a cardiac case. It was not a bypass case. It
Probably
was a
sepsis.
trauma case.
Oh, trauma?
Well,
It was trauma?
Case. And then
That's
we
kind of
ended up
unusual.
on ECMO after all the fluid had been given, So we didn't have the opportunity to treat it how we would in a cardiac case.
I doubt they actually had a capillary leak. I doubt they truly did, because you usually see that.
How would you know for sure?
How do you know for
How
sure?
would you know?
Because generally, you see it in sepsis. It would be very unusual for an otherwise healthy individual
Well, he
with
was
just
septic.
trauma. If he was septic,
He was.
well, okay. Well, in sepsis, then you really don't know for sure, but you can look at the clinical presentation and you're making a judgment call because you just don't know. But with that, when you have a capillary leak like that, if they are septic, the extravasation of water from your and proteins and everything else, you can't maintain a circulation. It's extremely difficult to control. And usually, like I said, it usually portends a very bad outcome. Tammy, let me talk to you about this if I can. You had mentioned in your slides that the hemoglobin if it was less than 8 or less than 7, that there was no difference in various metrics, including acute myocardial infarction or acute coronary syndrome. And I'm trying to wrap myself around this in that, hemoglobin equals oxygen transport. And so, if your hemoglobin goes down, your O2 transport, given the same cardiac output, also goes down. So you have to do something. Either you have to decrease demand, lower the temperature of the patient, or you have to increase cardiac output. So I guess I can't really understand why there was that difference.
Well, the study that I read said actually they didn't have enough data to make that determination, but that was their hypothesis, that it wasn't going to make a difference between 7 and 8. I think what they're getting at is tissue oxygenation is what your goal is. And higher hemoglobins don't necessarily correlate with that. And they were promoting in many of the studies that I read that we need to be thinking about different ways to measure tissue oxygenation. And it's not just by a higher hemoglobin. You have to look at the whole picture.
Well, that's a very good point. I mean, I would agree with that. That's true. You also mentioned that there was an increase in infection rate, death, MI, et cetera, all of these bad things we don't like to see happen with patients that receive transfusions versus not. But my question, and Keith, I want you to jump in on this too, is how much of that is contributed by the sicker patients needing the transfusion?
And there was
I had the same question.
Well, and that study actually addressed that you're not going to necessarily be able to know that for sure, but they did a lot of limiting factors where they had critically ill patients that were not transfused, and they had a statistically significant, although it's small, statistically significant differences in those. But they did acknowledge that some of that is going to be due to their comorbidities anyway.
Right. I feel like personally, I do a good job with blood management. I'm conservative about giving. So if I am giving a patient all of those products, it's because they are extremely sick or there's a huge problem in surgery, and then they're more likely to have a bad outcome, like you said.
Right.
I mean, it just makes sense.
Something I didn't mention in there because I didn't really have time to get into it. That particular study was fascinating. They actually, in one of the, I think it was a different study, I'm trying to think of who it was now, had a prediction that they thought harm would be caused with infection by giving transfusions too much. And harm would be caused by not giving transfusions enough in the ischemic category. And actually, when they got through with that study, their predictions were wrong. It was harm from both of them. Obviously, you know, you're going to have to give blood when you have to give blood, but they were they really thought that the risk of ischemic events would outweigh the risk of the negative blood transfusions, but that's not what happened.
Yeah, I think that is interesting. Keith, you could weigh in on this too, I guess, because what Tammy just described, I believe, is the old adage, you're damned if you do and you're damned if you don't.
Right.
So, that is a thing. And, since you're so heavily involved in AABB and all of these other organizations that function to only give transfusions when absolutely appropriate and not just because it makes us feel better. How do you address that?
Well, when I was racing through my slides earlier, it was like, wow, I should have said this or I should have said that.
Of course.
Do you remember when I was talking about the anesthesiologist, I said 8 to 10, no change. And that was something that was 3 different studies were done. One was done at Duke, one was done at Henry Ford, and I forget the other one now off the top of my head. But what they found after they looked at thousands of patients was that if somebody had a hemoglobin that was less than 8 and they transfused them, they actually improved. But when the hemoglobin was greater than 10 and they transfused them, they did worse. They had other problems. But between 8 and 10, it neither helped them nor hurt them. So it stands to reason that 8's the magic number. And I talked about that with the axial streaming of a crit of 24 or a hemoglobin of 8. That seems to be the sweet spot, the magic number, the place to be. If it falls below 8, you have to consider transfusing. If it stays above 8, you shouldn't even think about transfusing. And we're talking about all comers and all surgeries. Well, so that's
Yeah, okay. I mean, and I don't mean to interrupt you, but I gotta. Well, of course, I think you have to use every tool at your disposal. But there's just such a big difference between, an otherwise healthy 50, 60-year-old having coronary surgery to a kidney dialysis patient who maybe is 69 years old and not necessarily in the best of health, to a 78-year-old, very small, almost pediatric size frail female. And so, you know, I don't know. I mean, I've always practiced with considering the hemoglobins that I'm comfortable with based upon the patient's physiology that I'm dealing with at the time. And, you know, what's their body habitus like? What's their basic physiology like? And I think that individually there can be cases where a higher hemoglobin really, really matters. And I think that there can be cases where, or rather, let me rephrase that, where there's individual cases where you could get away with very low, you need really high. And then there's these statistical analyses that look at so many patients that you lose that individualization. And I think that's where practice habits come from. I don't know, what's anybody's thoughts on that?
Well, I think you make
diatribe.
A good point. And I think it's actually, it's a central point in what I think Keith and I were both leaning towards is you have to look at the big picture of your particular patient. You are going to do your best practices for them. But again, some patients are going to respond differently than others. I mean, some of them you can have a hemoglobin of 6 on pump and they look great. And others you have a hemoglobin of 7 and they are sagging. Right. And no other reason than that. Maybe they're all things being equal. You can't really figure out why.
I mean,
I think it's
you have to look at saturations, pressure, lactates, base deficits.
Yeah, we don't even measure lactates. We don't measure COP anymore. You know, why not? I used to measure COP on every single case. I don't think you could ask for one. They wouldn't even know what you're asking for.
I don't think they would.
Well, and I think wherever we're at, everyone involved in the care of the patient has to be on the same page. I hate nothing more than working so hard on bypass, getting a crit up to 25 when if I didn't work and like ride a little lower, it'd be like 20. And then as soon as we come off or go to the ICU, they're like, give 2 units of blood. Right. It drives me crazy.
I could just imagine. Keith, I want to talk to you about ultrafiltration.
Go for it.
So I've got a bunch of stuff. And also, well, first let me ask you this question while I formulate my question on ultrafiltration. Do you think that this thing you've taught me about, and how I just frankly never really even considered it. I mean, I might have heard about it 100 years ago, but no, in seriousness, in some basic biology book. But do you think the glycocalyx and how do you think perfusion can protect it? As perfusionists, how can we influence that? And do you think it's the new frontier of, perfusion, conduct of perfusion practice, kind of like back in the days when, we were looking at bubble oxygenators, membrane oxygenators, complement activation, nylons versus polysulfones and all that stuff that we were worried about then. Do you see this as the next new frontier first? That's question one. And then I want to talk to you about ultrafiltration. Go ahead.
Okay, so yes, the glycocalyx is the new frontier. Anything that has to do with microvascular fluid movement is now important, more important than it's ever been. So protecting the glycocalyx, there's 2 things that screw it up. One is volume loading. You have an anesthesiologist that gives lots of fluids quickly or gives boluses of fluids. That sloughs off the glycocalyx. The other is shear stress, as we talked about, pump on, pump off. So the one thing from the best paper that recently that I've read was Julie Wegner and Gerard Myers wrote a paper about the glycocalyx inject. It came out last year, I believe, and it talked about those 2 things, volume loading and shear forces, shear stress. And the one thing that they both came to, and Gerard and I fought for years about albumin. I was pro-albumin, he was negative albumin. But the one thing from all the literature that came out about the glycocalyx was you need albumin to protect the glycocalyx. So I'm very much a big proponent of albumin, not only because I think it keeps intravascular volume and colon osmotic pressure, but it helps to protect the volume of the glycocalyx so the fluid's not moving out. And we talked about this a little earlier. You said that trauma patient that got 10 liters of fluid. I think that they probably volume loaded him so much that erased his glycocalyx. And now you have that big capillary leakage kind of thing going on. Again, I think you have to stay ahead of that colloidosmotic pressure one way or another to protect the glycocalyx, to keep the fluid intravascular. And of course, when you have that fluid intravascular in your reservoir, hemoconcentrate it. Keep the fluid moving in to the intravascular and not to the extravascular. Ultrafiltration question.
That's a very good. Okay, now this is going to be a tough one. All right.
Oh.
There's recently an article that I read, and Tammy, I need you to weigh in on this as well. And Stephanie and Rodell, I don't know if you've read the article or not, though. It's by Mongero, however you say the name, and Stammers. And in this study, which was essentially it was a retrospective chart review, I guess, of many patients. It was big. It was a big review, but they found no benefit to transfusion reduction with the use of ultrafiltration. And of course, I found that fascinating, and it didn't make sense to me. I read the paper, and I was a little bit underwhelmed with the construct of it, but I think you know more about this than I do, so I want to punt it over to you and to Tammy regarding, it goes against everything that I believe passionately. So I'm trying to figure out if we can reconcile this.
Okay, so yes, I've seen those papers. They were in Perfusion Journal, and one was in JECT, and they're controversial. First of all, they retrospectively looked at a huge database. I mean, huge database. And what they did was they used multivariable binary linear regression. So it wasn't like it was a prospective, randomized. It was definitely observational, retrospective, using multivariable linear regression models. So when you have that many patients, and I think it was over 100,000 to start, and they narrowed it down to, don't hold me to it, but they narrowed it down. You could pretty much make anything you want out of it when you're using those linear regression models. So that's number one. I think what they said was that they broke it down into 4 groups: people that got X amount of volume, then another tier of volume, and another tier of volume, and finally the highest one was 2,500 mLs of ultrafiltration or more. But the long and short of it was, everybody at that table you guys are sitting at, and everybody that I know, and every case that I ever did, if I was to hemoconcentrate because I had extra volume, it always seemed to improve the crit, unless it was that scenario where they were a mitral valve and had 10 liters on board, and no matter what I did hemoconcentrating, I had to get to that quick, where I told you, you get to a certain point and now you're actually improving the crit. Otherwise, you're just recruiting volume from intravascular spaces.
Or extravascular spaces.
I'm sorry, extravascular spaces. I'm sorry. Yeah.
Okay. Yeah, I agree with you 100%, but I do think the paper is out there, and I think that it is, of course, it's my opinion. I think it is misleading, and it concerns me because I think that ultrafiltration is such a benefit to so many patients. And I'm curious, of course, now your opinion about this paper that's out. I don't know if you've read it or not.
I haven't.
But what do you think about, Rodell, you've been kind of quiet. What do you think of ultrafiltration? I know you work with some surgeons who don't like it, don't want to use it. But they don't like it because they think it stops urine output.
It stops urine output, and it inhibits the renal function, which I don't agree with. But, like Keith said, we're trying to get rid of extravascular fluid. I mean, that's my main goal. I mean, I'm not going to have, 3 liters in my reservoir that the patient doesn't need.
Well, especially when you put a liter there yourself from cardioplegia.
From
Exactly.
Cardioplegia. We use Delnido, and that is asanguineous cardioplegia. So I want to get rid of that after the fact.
Mhm.
You know, after we've
Well, you have the pump prime, you have the
Right.
Del Nido, you have pour fluid. They
Right.
suck out the chest when you don't want them to. You know, there's all these confounding
on
factors
top of
that anesthesia's pouring
Right.
fluid in,
Yeah.
and it's all just fluid.
Right.
The only ones giving albumin in that room is us.
So
Right.
I asked the surgeon then, that doesn't like, I said, I really want to hemoconcentrate this patient or we're going to have to give blood. And he said, yeah, concentrate it at the end. So I'm like, I don't understand. Why would I wait to the end? And I'm like already opening it up. And he said, yeah, with the cell saver, concentrate
Oh my God.
the red cells. And
There's
and then I
nothing
looked at
better
him.
than a surgeon who knows the pump.
Right.
So then he's like, well, I mean, do what you want.
Exactly.
So I did what I wanted. But
Yeah.
Well, and I had that same
you know,
scenario too.
that's not hemoconcentrating.
Right. I had a hematocrit of 20, and it was going to be one of those things. We were going to have to give blood.
Mhm.
I had already done everything I could do,
That's
and I could already see that, there's what they're sucking up and all of that. Next thing you know, I'm going to have a hematocrit of 17.
Mm-hmm.
And had that same discussion. And I said, I'm not going to do big volume shifts. I'm going to take off the cardioplegia and try to take off the prime, but nothing more.
That's pretty much what I said too.
And-
I'm just taking the extra volume that I
Right.
did.
I'm not trying to change. I'm only trying to change what I added. That's it.
Very good. So, in addition to that, now one last thing I need to ask is, on your Jehovah's Witnesses, everybody says treat everybody like a Jehovah's Witness,
That's
right?
the thing now.
Sure.
Treat everybody like a Jehovah's Witness. Okay. We don't operate on Jehovah's Witnesses who are coming to the operating room with a hemoglobin of 7.8.
Agreed.
That's true. They
And I do
won't
think,
do it.
right, I
They're
do
optimized.
think, well,
Well, I
they're,
think that's the point. We should be optimizing all non-emergent cases.
yes.
Agreed.
But again, I think somebody coming to the operating room with a hemoglobin of 7.8 that we're probably not going to ultrafiltrate much because they've already diuresed the patient
Right.
and they're desiccated. See, that's the thing. These anti ultrafiltration advocates don't recognize that we don't ultrafiltrate patients who don't have extra fluid to take off.
Right.
Right.
And if you did that, it's bad. We all agree with that. But we don't operate on Jehovah's Witnesses that are that haven't been given EPO for a period of time, tuned up. They're well nourished. They're usually our healthiest of patients.
That's a great point.
So, what do you think, Keith?
I think, again, you want to treat everybody like a JW with a small BSA. 8 is the magic number. You should never give people blood, meaning red cells, if their hemoglobin is 8. That's the magic number. There's more and more restrictive versus liberal studies that show that's the magic number.
Mm-hmm.
So that's sort of where I'm at about all this.
Well,
Okay.
I think on those patients, we have to do what we can, minimizing our circuit as much as possible, doing something I know you hate, doing wrapping and those sorts of things.
Oh, don't
I love
wrap.
You brought it
I
up.
love it.
Wrap. Rapping is the
biggest
worst
proponent.
thing ever in the world. The worst.
But
Worst.
Can someone
I'm gonna
call-
keep doing it.
Where's
should I
the
just
phone
should
number?
I
Where's
throw
the
it out
phone
there and
number?
do
Someone to call
prescriptive
in.
oxygenators?
Oh my God, that's even
No, we
worse.
can't do that.
Oh my God.
No.
Okay, this is deteriorating.
Yes.
Keith, is he still there?
Yeah.
I
Yeah.
really enjoyed your talk, and I'd always heard about the hemo bag, and I never actually used it. And I just wondered if you could give us an estimated, how much time does it take when you come off to concentrate that down and give back?
Okay,
In
so
minutes,
so in minutes it's 8 to 10 minutes
Okay.
before you're giving anesthesia a concentrated whole blood bag back. Remember, it's the same hemo bag. You fill, you concentrate, and you reinfuse from. So what you do is before you come off bypass, you give the field a 1/4 3/8 connector and a piece of discard suction tubing, like cell saver suction tubing,
Right.
a sterile one. They put the 1/4 inch into one of those blue or white ends of that, and they keep it on the field. They give you the other blue or white end, and you put it on top of the hemo bag, so that when they come off and they take the cannula out, they only remove the cannula, they make one connection in the field, and now you control everything. So you're
that's
able to
fantastic.
chase the whole circuit right into the hemo bag in front of your face. and you're watching your circuit get clean as you're chasing. So when you see that line coming into the hemo bag start to clean up or look like Kool-Aid, stop. So you're only adding more fluid. You don't want to do that. You want to do it quick. So from the time you fill that, from the time you start filling that hemo bag and chemo concentrating to the time you give it back to anesthesia is 8 to 10 minutes. It's very quick.
Have you had any issues if the ACTs were a little low coming off and then you're hemoconcentrating? No clot issues or anything like that?
No, I always say to everybody, first of all, I trained in Boston where we kept the ACTs 250 with a closed coded system, heparin coded system.
All righty.
And then,
Okay.
And then they ended up, last time I heard, they were up to 300 because the heparin changed and things changed.
It did
change. But even in Brigham is 350 now. You know, a lot of the places in Boston are trying to go a little lower with closed coded system. Remember, closed coded, meaning no cardiotomy.
Right.
If you're doing it, if you got to do a valve, you got to need a cardiotomy. Now you got to raise it up a little higher.
Right.
No air.
Right. Then there's the air to blood interface.
Yeah.
But yeah, it's the interesting part. I know you haven't been able to get an opportunity to try it, but there are videos on the website and on YouTube that are 2-3 minutes long to show you how to do it from start to finish.
Well, I'm glad you brought it up. I've actually used 4 of them.
You have?
I have. I've known Keith for a very long time. So I have used 4 of them and probably would have kept using them had I stayed in that place, but we didn't. We came here. But I do think this is a product that maybe we should be discussing.
I loved that he challenged people because you always hear that, oh, that's easy. I can make something.
Yes,
and
I
challenge
love it.
people try to do better than this. I loved that you did that.
I think, you know, and you bring up, I mean, it goes to what I believe, which is I believe, as Keith does, that the Cell Saver is a good tool. It's overused. The Impella is a good tool. It's overused. ECMO is a good tool. It's at times overused and misused. Transfusions are a good tool, but they can be misused or ill-used or overused or whatever. You know, and I think that giving the pump blood back versus going to the Cell Saver, I think has good utility, but it really does not have good utility for the acuity of patients that we're dealing with. You know, 80% of the time, otherwise healthy person, you throw a little bit of plasma away, it's not going to make a hill of beans for them. But if we're going to treat everybody like a Jehovah's Witness, if we're going to have this philosophy that we're going to do all we can to preserve that patient's blood is not only red blood cells. And so I think, Keith, to your point, you may be getting a couple of customers. I think we might be trialing it up here or something like that. If we could talk the hospitals into and the surgeons and find somebody who's interested to give it a shot. So if I could close out with asking you, so what'd you think of our program? What'd you think of the New Orleans conference online, Keith? Since you've been to the New Orleans conference as the New Orleans conference, how are we doing out here?
Well, Joe, you're definitely the innovator here. You're leading the way. I think everybody's going to be trying to catch up to you in the future. But right now, you got the ball. So I think you're doing a great job. I've watched a lot of your videos. You're certainly state of the art. Your studios are great. Your talkers are good. They're informed. I think that if we could get more people calling in and or sending in questions, I think that would be very, very helpful. You're certainly the key right now. You're helping out those people that need those points, and they don't have to pay for airfare, hotel, rental car, food. They can get their points doing this. The only downside, as you know, is you're not playing golf and going out to eat with networking with people.
That's true. I think that the personal networking, and we're trying to solve that problem, Keith. Actually, we're working on that. But I do appreciate it. You know, yes, it is easier for everyone, but I also, you know, at the end of the day, and I appreciate your words, I want it to be good. I don't want it to be a place where people could just come and get all their points and not have to spend time traveling and all, or can't get away because they don't have staffing, or they have no money because there's no CEU budget. There's a whole lot of reasons, but I want it to also be good and for people to really learn something and enjoy these programs.
Well, there is less distraction if you're not going golfing out to dinner and staying out late.
Well,
That's probably true.
So,
and the library is getting so big with different talks. You don't just have to watch it to get your points.
Right.
You can actually watch it because you want to learn something. Not,
Yes.
you know.
And it is free for, I didn't say this earlier, but it is free. You know, it's all of our programming is free to watch. You only pay if you need the CEU certificate. So I do think that differentiates us. You know, I'm going to be interviewing Bill Dubois on Sunday. And it'd be really nice. I know you're probably busy as could be, but it'd be nice for you to call in if you want to, and maybe because I'm going to ask him some questions, I think, and I'm going to let him give a talk on what his vision for AMSECT is in the future. I know you're a strong advocate of AMSECT. I have historically not been, but you know, I want to give Bill an opportunity to sort of, you know, I'd like to mend the fences. I don't think there's no point in that organization and I being at odds with each other, which we have been for many, many, many years. But I think with Bill in his leadership role, you know, he's at least there's a what is it called? Reaching out. What's the word?
Bridge.
What? No, those
Olive branch.
Well, olive branch. Yeah, at least he's reaching out.
Yeah.
At least there's communication.
Yeah.
There's never been, you know. So I'm happy with that. What do you think?
Yeah, I definitely would like to watch that talk on Sunday, but I may be golfing. So we'll see what happens.
You must be at a meeting. All right.
You know, I'll definitely do my very best, and I think that you're right. I think this is a good opportunity. Bill is a very interesting guy. He's an alpha like most perfusionists. And he reached out to perfusion.com. He reached out to you. He reached out to almost everybody. Look, AMSECT is still the leader of all the perfusion organizations. It's got the most, it's been around the longest. They really concerted, have a lot of volunteers that want to improve the field. So I'd like to, you know, clap for them if I could do that, and appreciate all their hard work. And of course, as I said to you, you're leading this charge now. All the younger people are only looking at their handhelds. And if you're going to be that person, it's going to make it easier for everybody involved. Then you're leading the way, and you are leading the way, Joe. So
well, thank you. Well, you know, I hope Bill understands, and I hope that I think you do too, that we're all stronger together. You know, I think having as many resources as you can, providing quality information, quality education, information in general to our overall community. We're such a small community, such a small fraternity with 4,300 of us. I think we're just stronger together than separated. So that's or individually. That's what I believe.
agreed.
Hey, I got one last thing. I wanted to say this earlier, but it just kept slipping away from me. You know how we talked about lymphatics and how it doesn't work because you're paralyzed during bypass?
Sure.
And so here's the key. You got to get extubated because they're not going to let you out of bed and move until that tube's out of your mouth. So the lymphatics, again, are not working until you're able to move, bend, turn, stretch. That skeletal muscle movement is how lymphatics work. So I'm sorry to chime in so late with that, but that's why you need to get the extubation. You need to get it to let you move around, and you can get that lymphatics moving again.
That's perfect. Well, I want to thank our wonderful panel. Stephanie, Rodell, Tammy also gave the presentation. Keith, you out there in web world, giving 2 excellent presentations. Both of you, I learned quite a bit from you. And tomorrow, don't forget, we start at 9:45, 10 o'clock tomorrow morning, Central Time Zone. So make sure you tune in for day 2. And we're going to have a great day tomorrow with some real interesting talks. Debbie Adams is going to be here. Dr. Gersak's going to be here. Or no, he's going to come in via Skype because he's in somewhere in South Dakota. I think they have internet there. I'm not positive. Dr. Body is going to be here. Yeah. I think Dr. Matoyer is going to stop by. So we've got a real full day tomorrow with a lot of you're going to be here. Mm-hmm. You guys are going to plan on being here? Maybe?
We're planning on it.
Planning on being here. So that's good.
We have one on call.
One on call. So we'll have at least one of them here. And we'll see you all tomorrow morning at 9:45. Good night. And thank you again so much for the first day of the New Orleans Conference 2019 online edition. See you tomorrow.